Hello. Hi, Kirsty.
Hi.
Kirsty, do you just want to share screen and check that it works well? Kirsty, that table, are you going to, that table I just thought was a bit too busy. That was the only comment from my observation.
Sure, Prof. I'm not going to say much about it. I'm just saying a sentence. I just wanted to have it there so people could see.
Okay. Okay. But then point out to whatever you want to point out, whatever information you want to point out.
Sure, I will do.
Thank you. Okay. That's fine, Kirsty. And are those X-rays on your presentation, what Dr. Sonia is going to talk about? Are they on at the end of your presentation, Kirsty?
No, Prof. I have a second one separate for her. This one.
Oh, okay. Okay.
Yeah.
Okay. And so you will project it and she is going to talk. Is that correct?
Yes, Prof.
Okay.
She did just send me a message now to say they're just finishing in theatre. So I'll just check with her. I'll just check that she has joined when I finish.
Okay. Okay. That's fine.
You
do not know much about those patients, do you? In case she cannot.
No.
Okay.
No, unfortunately not, Prof.
No, that's fine, Kirsty. That's fine.
I don't think it'll matter too much. She said, I mean, yeah, I don't think it'll matter too much if she's not able to join.
That's fine, Kirsty. We'll just see if she, by the time you are about to finish, we will know if she joined us. Then, otherwise, I just invite Mr. Parekh to comment.
Sure.
Otherwise, Kirsty, how is studies going on?
They're going all right. Thanks, Prof. It's a bit hard to study in between work, but it's okay.
Yeah.
I had pretty much finished my preparation for the last time, so
yes,
there's not much to do except for revise papers.
Absolutely.
Yeah,
absolutely.
I can only really do last week.
Okay. Kirsty, I'll try and remember, but remind me on Monday when I'm back that you trainees can also become a member of Associations of Surgeons of South Africa, ASA, and it is free. And the useful part for you people is that they regularly conduct tutorials for primary and intermediate examination.
Oh, okay. Okay. I was aware of one of the other, there's also UCT also does some via Zoom.
Correct. I think it could be the same UCT tutorial, but I'll try and remember. But if you haven't, I'll set up an email only to come to you people on Monday or so. But if you haven't received my email then no, but you will be on leave next week. Am I correct?
Yeah, I won't be. Unfortunately, won't be there Monday.
Okay, okay. No, that's fine, Kirsty. I will just keep it in mind when you come back from leave if you haven't received my email.
Sure. Helga did send us the link to those UCT ones a while ago when we started studying.
Right, but I just want all of our staff to register for that ASA website. And so the juniors who are preparing for the primary and the intermediate, they can at least be aware of those tutorials.
Sure, Prof.
Hello, Dakshesh. Good afternoon. You'll need to unmute yourself, Dakshesh. Just unmute yourself.
Yeah.
Okay.
Is it okay?
No, that's perfect. Do you want to just try and share your screen and we can just go through one or two of your slides?
Where do I share?
You need to keep that presentation open on your PC.
Yeah.
And then right at the bottom, there is this green sort of arrow, share screen.
Oops. In the PowerPoint or in the?
No, on your PC or your iPad.
Share the screen. Okay, yeah, got it.
And you just click on that.
Yeah.
And then it will open Windows, which window? And then you need to click on that PowerPoint presentation.
Desktop, share. It is open. I don't know what happened. Oh.
Dakshesh, I keep my video off because I'm sharing my office with our son.
Okay.
You can keep it on or off, it's up to you.
I'm trying to share the screen. So
Yeah, no problem. You just need to click on that share screen tab and then click on the PowerPoint.
Okay, Microsoft PowerPoint.
Yes.
Share.
Yeah. Is your PowerPoint presentation open?
Yeah, it is open. I've made it smaller, but it's not opening.
No, if you click on that green upgoing arrow, share screen, it should open Windows those windows for you.
Yeah. It's not opening.
Now you just need to click it.
I can see you as well as my PowerPoint, but it's not going into your share screen thing. So I
Okay.
don't
What
know,
other?
something I'm doing wrong.
What you can do so long? Maybe just email it to me.
I have emailed you.
Have you? When did you do it?
Yeah, a few days back when you asked me to send your email presentation, and I
Okay.
had
Okay.
sent it to you.
I'll check it now. I'll check it.
I will ask my son whether he can share the screen.
Yes. Yes. Please.
Just hang on.
And don't stress. We will wait for you.
Okay.
Yeah.
Okay. Share the screen, the PowerPoint presentation inside this. You share this. I try to share the screen to show my PowerPoint presentation. Where is it?
Which one is it?
It should be basic. Will it be in desktop or PowerPoint?
I don't know. Where did you save it?
It's on a desktop there.
Is that it?
Yeah, well, why does it say unknown?
I don't know where you saved it, so I can't help you.
No, it's up here. Look, it's on a desktop. So there.
I don't know where it is.
It's on an iCloud desktop. Say, for example, Microsoft Google Drive. No.
Lakshesh, can you please email me the presentation once again? I don't seem to find it. So maybe you can just email it to me and I can project it
Don't
then.
use this. No, don't use this. Use Microsoft Teams.
So it's here. So
Switch off your camera and the mic, and then I'll try and do it.
okay, here. Okay.
Good afternoon, everyone. Sorry for the technical glitches, but they are part and parcel, and probably like the spice of these Zoom meetings. It's my pleasure to welcome you all to this meeting of the Department of Pediatric Surgery. And today, Dr. Kirsty Pedersen, who is our medical officer, is going to talk about empyema thoracis in children. And we are really very honored to have Mr. Dakshesh Parikh as our invited guest today. Dakshesh claims that he is a retired consultant pediatric surgeon, but he finds out a reason to try and come and assist either his colleagues or his patients in Greater Birmingham area. When I looked at Dakshesh's CV, it was very pleasing for me to know that he trained where I trained in Mumbai, not in the same institute though, and I trained 4 or 5 years after him. And subsequently he trained in Liverpool, and he also did a fellowship from Glasgow, where both Dr. Lazarus and I have strong connection. Dakshesh is deeply involved in teaching and training and mentoring throughout his career, and he continues to do that even post-retirement. And this includes local and overseas training and young consultants during this period of COVID. Dakshesh has been or is a principal editor of 2 books on pediatric thoracic surgery. One is a new or a recent one, Tip and Tricks in Thoracic Surgery. And a second one, which I am proud to have, that I owned a copy, which I've given to the library, is almost like the Bible of pediatric thoracic surgery. He has given over 100 invited lectures and has more than 100 publications. And he says that he's just waiting for the COVID nonsense to be over so that he can enjoy his retirement and do what he loves outside medicine, that is to travel, to do photography, and to enjoy sports from all faculties. So Dakshesh, we are really very honored to have you today as our invited guest. So I'm going to stop sharing now, and I'm going to invite Dr. Kirsty Pedersen to give her talk about empyema thoracis in children. Kirsty, we have audience not only from our country, but as far as New York, Caribbeans, Pakistan, and including our colleagues from East London, some retired, some working, and also from Queenstown. So please go ahead. Thank you, Kirsty.
Thanks, Prof. Sorry. As Prof mentioned, I'll be speaking about empyema. I'll look briefly at the definition, classification, causes, and then settle on pathogenesis and management, and then have a brief overview of how we manage it in South Africa. So empyema falls under parapneumonic effusions. This is collection of fluid in the pleural space. And empyema is then defined as an accumulation of pus in the pleural space. They can be classified according to the system into classes of 1 to 7. Class 6 is a simple empyema where frank pus is present and a single locule or free-flowing pus. And class 7 is a complex empyema with frank pus present and multiple locules. Causes of paramnemonic effusions include those from adjacent infection, a reaction to a subphrenic abscess, extension of infection from the mediastinal, retropharyngeal, or paravertebral infections, infection post-thoracic surgery or trauma. A collection can form after intrathoracic esophageal perforation, or it can be relating to a neoplastic process. This fluid can then become infected. So the pathogenesis of an empyema forming is described in 3 stages by most sources. A few of the sources, however, add a 4th stage, which is a pre-collection stage, which consists of pleuritis and inflammation. Stage 1 is the exudative stage, where there's a simple paramnemonic effusion. This is clear, free-flowing pleural fluid. The fluid is often sterile when tapped. In stage 2 is the fibropurulent stage. This is a complicated paramnemonic effusion, also known as empyema. The fluid here has been invaded by infective organisms. This causes deposition of fibrin and purulent material in the pleural space. There are septations and fibrin strands which start forming, and it results in the development of loculations of purulent fluid. In stage 3 is the organization stage. This is where this thick fibrinous peel is established. It can entrap the lung and cause restrictive lung disease. So investigations in these patients, primary investigations would be your blood tests, where you do infection markers and a blood culture. Then the fluid from the pleural space can be tapped and sent for fluid chemistry. Looking at the fluid, you use Light's criteria to define a complicated paramnemonic effusion or empyema. This is defined by pH less than 7.2, LDH more than 1,000 units, glucose less than 40 or less than 25% of the blood glucose at the time of the tap, a grain stain or culture positive on the fluid, and then loculations or septations as seen on imaging. The imaging options, you would start initially with an X-ray. So chest X-ray will show a consolidation. It can sometimes be difficult to distinguish between parenchymal and pleural disease on X-ray. X-rays can show a blunting of the costophrenic angle, a fluid meniscus, and then movement of the fluid on lateral decubitus if it's stage 6, so simple pneumonic, or if it doesn't move, then you think of a complex paramnemonic effusion. On ultrasound, ultrasound is then sensitive for diagnosing loculated fluid. It can be used to guide the drainage and catheter placement. It can reliably differentiate between parenchymal and pleural-based disease, and is thought to be superior to CT scan in diagnosing empyema, and it also has less radiation risk to the child. CT scan thus should be reserved for complicated cases or preoperative planning. So management consists of antibiotics, debridement, and drainage. So when we look at antibiotics, high IV dose antibiotics are used. In a small effusion, which is less than 10 millimeters on a lateral decubitus chest X-ray, or less than 1/4 of the hemothorax, these can be treated with oral antibiotics and as outpatients if the patient is stable. Larger effusions will require 10 to 14 days of IV antibiotics. And in complicated empyema, oral antibiotics can be continued for 1 to 4 weeks after discharge. The most common organisms that are cultured from the pleural pus in patients with empyema are Streptococcus pneumoniae, Staphylococcus aureus, and Haemophilus influenza. Fluid cultures and blood cultures can often come back without growth of an organism due to the children being on antibiotics for the pneumonia preceding. Protocol is to start broad and then narrow down your antibiotic choice as cultures or the clinical picture directs. Literature suggests to start with cefotaxime or ceftriaxone, and then to add clindamycin or vancomycin if MRSA is suspected. In patients with TB, empyema is much more rare than a simple TB pleural effusion. But if it is suspected, then TB treatment should be started. Drainage of the fluid should be decided on patient symptoms, the size of the collection, and response to antibiotic treatment. So single thoracocentesis can be helpful in draining small collections of fluid, as well as in collecting a sample of fluid for culture. If multiple thoracentesis is needed, it is then advisable to rather insert an intercostal tube or drain. The indications for a chest tube will be an opacity larger than half of the hemithorax with more than 10 millimeters on lateral decubitus X-ray for a child that's in respiratory distress, and if the fluid is consistent with empyema on investigation. The insertion of a chest tube should be considered also if a patient fails to respond despite 48 to 72 hours of antibiotic therapy. Looking at debridement in these children, there are two types of debridement that can be done. One is chemical and the other is operative. In treating of empyema, adding debridement agents to chest tube placement proves superior to chest tube drainage alone. The chemical debridement is with fibrinolytics, namely urokinase or streptokinase or tissue plasminogen activator. All three of these fibrinolytics have similar effectiveness. Deoxyribonuclease is a mucolytic agent that can be added to treatment. This enhances the effectiveness of the fibrinolytics by debriding the pleural space. Operative debridement is done via VATS, video-assisted thoracoscopic surgery. Current literature just suggests to give IV antibiotics, insert a chest tube, and give 3 doses of fibrinolytics. If this fails to have a clinical response, then to repeat imaging and operate if there is persistent disease. Other indications for operative intervention include empyema with significant lung pathology, bronchopleural fistula with pneumothorax, or a secondary empyema. Both chemical debridement and operative debridement have shown to have similar outcomes for patients. Yes, Prab?
Sorry, sorry for interruption. Some attendees are saying that the slides are not progressing, and Cello had just advised we restart the meeting. Cello, can you unmute yourself and please give your advice?
No problem. Thanks. I was saying that can restart the Zoom meeting, not the whole presentation. The person who's having issues with the video can just log out and log in again. It might help because we can see the slides progressing well.
Only those people who are having problem.
Yes, they can just leave the meeting and rejoin. It should be able to help.
Okay, so those people like Dr. Kevin Waite, who are having problems, just maybe exit the meeting and re-enter the meeting. We will continue the meeting in the meantime. Thanks, Cello. Sorry, Kirsty, you can proceed.
Sure, Prof. Sorry, so just to finish on that, debridement is chemical operative, and both chemical debridement and operative debridement have shown to have similar outcomes for patients. Then I thought I found 2 studies that were done in South Africa that I thought I would share. So the first study was conducted at Chris Hani Baragwanath Hospital in Joburg. Their objective was to describe the etiology and management of empyema in a setting of high HIV and tuberculosis prevalence. A retrospective descriptive study was undertaken between 2012 to 2016. 65 patients were included in the study. So the findings were the commonest cause was Streptococcus pneumoniae, followed by Staphylococcus aureus, which is similar to the global findings. And then Mycobacterium tuberculosis accounted for 10 to 14% of cases. Although fibrinolytics or early surgery are recommended by literature, neither practice was very common in this setting. The median duration of hospital stay was 18 days. All of the children received antibiotic therapy. 91% of the children required pleural drainage. Fibrinolytics were only documented in 9% of patients, despite 91% requiring drainage. and 12% had a thoracotomy open, and 10% had video-assisted thoracoscopic surgery, or VATS. And then they found a high proportion of the HIV-infected children with Empyema when initiated on TB treatment, possibly incorrectly. So this just highlights again the challenge that we face in managing TB and HIV co-infection in our country, which are then often complicated with Empyema. Sorry, I don't know what's written. A second study sorry, Prof, give me 1 second. Sorry for that. A second study conducted at Red Cross Children's Hospital in Cape Town looked at the impact of fibrinolytics in the treatment of children with Empyema. A prospective observational study of children with Empyema was done between 2006 and 2011. In their hospital, intrapleural tissue plasminogen activator was administered according to a standard protocol. This was introduced in 2009, so midway through the time that they looked. Outcomes in the children that were treated with TPA after 2009 were compared with a historical cohort not treated with fibrinolytics who would have met the treatment criteria. So in total, they looked at 142 children with Empyema, 59 in the pre-fibrinolytic group and 52 who received fibrinolytics. 95% of the children had a chest tube inserted. 38% were not treated with fibrinolytics and required surgery, compared with 9% of those who were treated with fibrinolytics. So there was a big improvement. So they concluded that intrapleural TPA resulted in a 4-fold reduction in surgery, and that fibrinolytics should be used for the management of Empyema in children in South Africa. This is especially important as thoracic surgeons are a scarce resource. The prevalence of TB was also again nearly 10%, which highlighted the importance of TB as an unrecognized cause of Empyema in our setting. So just to conclude for Empyema, paraneumonic effusions are very common in children with pneumonia. Up to 50 to 70% of children who have pneumonia will develop an effusion. These become complicated by infection and can form Empyema. Chest X-ray and ultrasound are the cornerstones of investigation. The commonest organisms to think of are Streptococcus and Staph aureus. In South Africa, TB should also be considered. A conscientious path should be followed when managing a case of paraneumonic effusion in children, as the severity of the case and the progress of the disease can usually dictate the approach. Primary management should consist of antibiotics, drainage, and fibrinolysis. Operative drainage should be reserved for those cases who do not respond or complicate further with other lung pathology requiring surgery. However, this view is currently under review. One study previously done, which included over 3,000 children, concluded that although national trends favor chest tube and fibrinolysis, primary VATs are associated with a shorter hospital stay and a shorter PEDS ICU stay, as well as a low requirement for ventilation. They suggest that further studies should aim to risk stratify children who may suffer from a protracted course of disease, with a goal to offer primary VATs to the subset of children and return them to normal life more quickly. Overall, the prognosis for these children with Empyema is good. Most studies show a resolution of the chest X-ray changes within 3 to 6 months after completing therapy. Those were my references. Thank you.
Thank you, Kirsty. You can, I think, present those interesting X-rays of the patients, which Dr. Sonia van Reet, thoracic surgeon, will talk about. So now Dr. Pedersen is going to project some images, and I invite Dr. Sonia van Reet, who is a thoracic surgeon who works in our hospital, and she primarily nowadays deals with these thoracic problems. So in next like 5 to 7 minutes. She's going to present a couple of patients before I invite Mr. Dakshish Parikh to give his advice and his talk. Okay, Kirsty, go ahead.
Hi, Sonia. You just need to unmute yourself in the bottom left-hand corner.
Sonia, can you talk? Hello, Sonia.
Yes, can you hear me?
Yes, yes. Yeah,
Okay,
good.
all right. Okay, so the patients we see are maybe somewhat different from the European patients. And the problem is that most of the patients I see present a little bit late. Chrissy, I think this new care stream view system, unfortunately, has sort of mixed up some of the X-rays, which I only realized after I'd given you the names. So this child was Tapolisi, a mentally retarded child who fell from a tree and had a big hemothorax. But due to previous chest infection, it was loculated. So we only, I think, saw the child a few days only after the initial trauma. So just continue to the next X-rays if you can. You just sort of slide through them all, Christy. Drains were put in by other people, and then because it was loculated, I think a CT scan was done. We tried to drain that specific space, which also didn't really help, because by this time it was the fibrin deposits were thick on the lungs, so it didn't expand well. Unfortunately, for 4 weeks, there was no space in Pete's ICU and no surgical space. So he had a decortication only 4 weeks after the initial procedure. But he is recovered well, and the lung is now well expanded after the procedure. Yeah, I don't know where that X-ray comes from. So they're just not in series totally. But the child was last week at the clinic, and the lung is well expanded. The child is active. So we can go to the next child, which is a small baby who presented also to the pediatricians with a staphylococcus pneumonia with a pneumothorax. Responded well to its acute situation by insertion of a drain, and it was a very sensitive staph, and it had responded to cloxacillin. But it's now left with a residual sort of all kinds of things in the chest. That is, it was better at one stage, but it's now worsened again. The child is not running a temperature, and I think they're fibrin deposits. And also, once again, in our situation, fibrinolysis is a bit complex and also cannot be done in such a small child. If an ICU bed is not really available. So we want to decorticate the child, because this is a rather complex pleural space. Unfortunately, the old packs was down, because what I wanted to show was now adults who were treated as Empyemas at Cecilia Makiwani more than 20 years ago, and now sit with calcified, sort of contracted chests, since it was not completely drained. And sometimes when the pleura is thickened, one should go and strip out that pleura to get the lung and the chest to expand properly. Because once that chest shrinks up and cannot develop in the child, it's really not good. So I just request, please, for the children, if there is any problem with the X-ray not looking normal, to refer them to me, that I can just follow them up. And if that chest should contract, to rather early do something about it. And and in our situation, well, except that we can't really do the VATS don't have VATS equipment and the means to do it. It's these empyemas are very, very complex, and they advance when we see them, and VATS will not really be possible. So I just ask for early referral and early insertion of drains, and for regular review, which I'm prepared to do. So that is my whole story.
Okay.
Because we want to save lung in our society. And the other problem that we have is we see quite a number of ruptured hydatid cysts into the pleural space. And you don't see the water lily or anything anymore because it has become a total empyema, and the membrane has mostly dissolved. So that is another thing that we often have to think about. Okay,
Yes,
that's
thank you.
all I.
Yeah, thank you, Sonia.
Okay.
Thank you very
All
much.
right, thank you. Bye.
Yeah, you have highlighted our problems, that unfortunately we get patients referred not early, which we would like to, quite late. And our problems are complicated by problems like HIV and TB and things like that. So Kirsty, if you can stop sharing, I will now invite Mr. Parekh to share his screen and then give his talk. Dakshesh, thank you very much for waiting patiently. Now we are ready to listen to your talk and your advice. So please go ahead and you can start your talk.
Can you hear me now?
I can hear you nicely and we can see your presentation also. You can go ahead, please.
That's great. It's worked out well. Then eventually, after going on and off, on and off. Hi, hello everyone. This was my talk, which I gave to adult European Society of Thoracic Surgeons in Vienna, and I thought it will be the same talk, which will be useful because it's a mixture of the audience was mixed, and I thought maybe it's easier rather than me doing an entirely new talk. So this was given to in Vienna in October 2017. So my main work was in Birmingham Children's Hospital. And I'm sure Kirsty must have said various things about empyema, which is accumulation of infective exudate, which we described increasing incidence in UK first in Lancet in 1997, and then subsequently many other authors reported increased incidence around the world in Western country. And in spite of having 7 valent pneumococcal vaccination, has not reduced the empyema amongst the Western world. And the studies from USA suggest that it has increased even further than it was before. However, the incidence of pneumonia has fallen. So maybe as the time goes by, it might reduce, but time will tell. So as somebody said, post-pneumonic empyema is the commonest, and the secondary empyemas are related to trauma, surgery, esophageal injury, subphrenic abscess, hydatid or infected CCAM. But they are called secondary empyema, as Kirsty has highlighted. Pathological stages, which you might have described as 1, 2, and 3, is never uniform, and you will not see in a single stages as you would see in clinical practice. An empyema is always a continuum. So basically, you will see a combination of all 3 stages in one case, and you will never see entirely exudative stage, entirely fibropurulent stage, and entirely organization stage. However, very, very late stages, you will see organized, like thoracic surgeon described that it is a calcified situation. Clinical features or symptoms are standard and related to the respiratory compromise you will see. And that depends on extent of the lobar consolidation and rapidity with which the pus accumulates within the pleural space. So the acuteness of symptoms will depend on these 2 factors. However, the clinical presentation has various other factors which are triad of a situation, which is host immunity. So if the host immunity is low and the organization is more powerful, then you will get a severe presentation of empyema. And if you have inadequate management, then you will have a chronic or subacute presentation which is prolonged in situation, and you will have a late referral. And as discussion went on, then there you have a two modality of imaging, ultrasound and CT scan. We tend to do CT scan in almost all cases, but ultrasound is the available at bedside and done primarily by many respiratory physicians before referral, and it shows, confirms the diagnosis, shows you loculation, thickness of fluid and pus in the pleural cavity, and also can guide chest drain placement depending upon where the loculations are. And that has been done by the respiratory physicians who insert the fibrinolytic agents through a pigtail catheter. However, CT scan can exclude the lung pathology, which is not possible on ultrasound, can identify loculation as for ultrasound as well. Thickness of the thickness of fluid can be done by attenuation value within the pleural fluid, and you can say is it thicker or less thick, and accordingly you can judge or tailor your treatment. We had 7 children with empyema-like presentation, which turned out to be tumors, as you will see in this one. And I'll talk to you about it later. It's reported in 2006 in Pediatric Surgery International. So value of CT scan, as you can see the necrotic lung in this area, which you will not be able to see it on ultrasound alone. Infected hydrated cyst, which was already mentioned before, and you can see the liver hydrated disease. So it probably that distinguished the problem. We had this case from Zambia, which came across to Holland, and he was studying in rugby school because the father was working in a WHO, and he came to us with this condition, which we never see. We can see the infected cecum, multiple lung abscesses, which you will not see otherwise. This girl was anorexic and throwing up by putting the fingers in the throat and was aspirating. So she had multiple lung abscesses, which you would not have identified. And bilateral empyema also is very difficult to identify if you just do an ultrasound on basis of ultrasound alone. So important part of management principle of empyema is achieve early diagnosis. That is, if you want to get good results, achieve adequate drainage, which is whether you will do fibrinolytic agents or thoracoscopy or thoracotomy. Important thing is to achieve adequate drainage, but at the same time monitor your progress. So if you, whatever management you have employed strategy, you must monitor the progress of the treatment employed, and so that you can achieve full expansion of lung. This is the most important part of empyema management. Whatever treatment you will do, whether you do full circle from Hippocratic time or now, you have to have complete drainage of empyema, complete drainage of fluid from the pleural cavity. So as you discussed intrapleural fibrinolytic agent, we were part of that study, and you can achieve a good result if you identify the empyema early. Our strategy was always primary surgical intervention with VATS, but you can have failure of intrapleural fibrinolytic, and if you identify that, and you can refer to a thoracic surgeons for VATS or thoracotomy, depending upon the stage of empyema. But however, you'll have to do surgical intervention if you have a persistent sepsis and collection, a late presentation with pleural peel and trapped lung, complex empyema with significant lung pathology, which I'll come to you later, and pneumothorax with bronchopleural fistula. You cannot do it with VATS alone. You will have to do a thoracotomy. We presented to BAPS a couple of times our audit on VATS, once in 2008 and another time in 2019 for VATS of Department of Empyema. This is in respect to what a study which we had with RCT with VATS with fibrinolytic agent at that time was in a 16.6% VATS failure. So with that in mind, we conducted our audit to see what outcome we had. And we had 122 children in our study. 8 had a primary thoracotomy for bronchopleural fistula and were excluded from the study. And we had 114 children which had a pure VATS. Age, onset of symptoms, operating time, duration of chest drainage was only 4 days, and post-operative stays was 7 with range of 4 to 36 days, depending upon the situation. We had 8 treatment failures, 5 converted to thoracotomy due to failure to progress and release of trapped tongue on table. We could not release the trapped lung and therefore converted to open, and 3 had recurrences following inadequate thoracoscopy by other surgeons, because we had 7 surgeons doing the thoracoscopy, so it's difficult to maintain the same uniform outcome. We had few complications, but all were managed conservatively. So during that time, we had about 8 to 10 series published, and our series showed that we had 2.6% failure or conversion rate. Length of stay was 7 days, and total chest drainage about 4 days. So compared with others, which is the commonest one was Kang et al., which is comparatively similar to us, but they had 1 death, and the length of post-operative stay was not specified, and length of chest tube drainage was 9 days. So in conclusion, this is very important. VATS debridement has a better outcome than recently reported randomized control trial. VATS is effective primary treatment for empyema in experienced hands. So this is important. You do need to have a little bit of experience, but it's not difficult to learn debridement by VATS. If you can do a thoracoscopy, this is a very simple thing to do, or relatively simple thing to do. Complication rate is low. Hospital stay has significantly reduced longer when treatment was delayed. So if the treatment was referral was late, the hospital stay was longer. VATS achieved adequate drainage, full expansion of lung with minimal morbidity and no mortality. Complex empyema should be recognized and managed appropriately to reduce the morbidity. And this is what I mean by complex empyema. Empyema associated with significant lung pathology, such as lung abscess or bilateral disease or trauma, I define that as complex empyema. So pneumothorax or necrotic pneumonia, lung abscess, infected lung lesion or parasitic lesions, pancreatic trauma or blunt injury, and followed by infection, a sort of hemothorax getting infected, subphrenic abscess and rupture, bilateral empyema, and infected post-lobectomy space. So these cases are considered as complex empyema and has to be treated probably with open thoracotomy. So if you have associated lung abscess, you can treat empyema as it is, not open the lung abscess as such, and treat with appropriate IV antibiotics, and that should resolve the lung abscess with conservative management in most instances. Necrotizing pneumonia with spontaneous bronchopleural fistula. And this is what I mean, where there is a significant necrotizing pneumonia, and it has leaked out spontaneously to cause pneumothorax. And in this case, we tend to do mini thoracotomy, drain the empyema adequately, decorticate parietal and visceral pleura, and insert serratus anterior digitation flap, which I have described and published in the literature. This is my description of digitation flap, which I'll show it to you how it is done. So why we prefer serratus and why we have done serratus anterior digitation flap is because every digitation of serratus anterior has independent nerve supply and blood supply. And it is part of lateral thoracotomy incision, so you don't have to take a separate incision. Raising this muscle flap or digitation from the anterior insertion is very easy because you just raise up from a periosteum and it comes out if you don't damage the lateral thoracic nerve and the blood supply coming from the side, and does not cause long-term disability. And I'll show you the results of that. So this flap was described by me in 2004. So we analyzed the efficacy of our digitation flap, and we had 20 children between 2000 and 2010 with pneumothorax. Clinical resolution was achieved within 2 days. Chest drain was removed 7 days, median 5 to 15 days. Hospital stay was 9 days, and no re-intervention. Lung resection was required. So it preserved the lung parenchyma, and long-term follow-up showed full resolution and no skeletal deformity. So that is one of our case, as you can see in post serratus anterior digitation flap, complete expansion and no scoliosis or anything like that. So these are the cases. So if you see this case who had large empyema with lobar, the whole lung consolidation, had pigtail catheter inserted by respiratory physicians in the periphery, and subsequently developed a pneumothorax with pigtail catheter in situ. You can see the CT scan with necrotic pneumonia and pigtail catheter in situ. On table, you can see there was a hissing sound with the necrotic pneumonia with bubbling of air coming out from the lung. We inserted the serratus anterior digitation flap onto the fistula and sutured the lung parenchyma around very loosely, and that is the outcome post-op. So you can achieve good result after just a simple intervention, but taking care not to damage the serratus anterior while you're doing a lateral thoracotomy. Another case was a large consolidation pneumonia in a child which was admitted to ITU, and you can see just about the chest tube, endotracheal tube ventilated. This child had also got a pigtail catheter, a very small one you can see here, and was managed in ITU with a pigtail catheter and the fibrinolytic with IV given through central line. And as the time went by, they had done a CT also with no improvement. And you can see the necrotic lung. By the time they called us, child had developed bilateral lesions with overflow infections on the opposite side and a pneumothorax on the same side, and develop a significant pneumothorax within hours, then the tension pneumothorax with no time. By the time they couldn't maintain the ventilation, and therefore they inserted 3 chest tubes, which were bubbling away like nobody's business. And they could not maintain the oxygen saturation. So we intervened in emergency and inserted the serratus anterior digitation flap onto the fistula, and that is the outcome. This is a real outcome. This child is doing exceedingly well now. So, you can improve by early intervention, and outcome can definitely improve. So that is me. Thank you for listening. Any questions?
Dakshesh, thank you very much. I mean, I haven't read your recent publications. So this serratus anterior flap was quite a, it was very exciting new knowledge for me. So thank you for that. And I always have appreciated and still appreciate your humility and modesty, because I mean, you are one of the pioneers of pediatric thoracic surgery, not only in the UK, but throughout the world. And you really, you never show off what you have already achieved. Now I'm going to invite, there are other sort of senior people who are attending the meeting. So I'm going to invite one by one some of them. The first one is Professor Larry Hadley. You may know him, Dakshesh. He is retired, but he's still quite involved, and he enjoys attending our meetings. So, Prof. Hadley, please give your comments.
Yeah, Dakshesh, thank you very much. It's always lovely to listen to an expert talking about the field in which he is an expert. On your list of complex empyemas, I didn't see the word tuberculosis. Does TB associated with an empyema make it into a complex empyema that's more likely to need a thoracotomy?
We don't see TB as commonly as you guys do. I think in my experience in 25 years, we have seen MDR about 3 times, which came from infectious disease place, and we had to do a lobectomy. But empyema infection-wise, we have seen only 2 cases of TB with pleural effusion. No, I haven't seen, I cannot include TB because unless you get a secondary infected TB pleural effusion, usually it's a very serious pleural fluid, and that tends to control the tuberculosis infection within the lung because it collapses the lung. And that's my personal opinion, that because you have a plombage or closure or lung collapse, the TB within the lung tends to remain within the cavity, and then that tends to, if you give a anti-tuberculosis treatment, improve the outcome. But we haven't seen, so I cannot be expert in TB. So I'm sorry, I wouldn't say the TB is I wouldn't include that as a. In my personal experience, anyway. You may be able to because you see very complex TB.
Yeah, one of the lovely things about retirement is that we can say, we'll ask Sonia. But thank you very much indeed for your contribution today.
Thank you, Prof. Hadley. Sonia, do you have any more comments before I invite comments from our other consultants?
Prof, it's just that TB is a very real and very huge problem for us, and to manage those lungs is very problematic. Yeah, because often it's associated with HIV, with malnutrition.
Yeah.
So these problems are very complex for us to manage, and most of them, like in adulthood, they manage as very long-term problems, and they attend our clinic on regular basis until the space is clean, and then some kind of the thoracoplasty, etc., is done. Which is very challenging. The surgery, everything about them is very challenging. So yes, it's what the problem you highlight. It's about early treatment, and that's where VATS, etc., and proper drainage at an early stage comes in. And that is why get somebody involved who will place drains correctly and not little pigtail catheters that are not going to work. So yes, that is all I can ask. And TB for us is a very, very real problem.
Huge problem.
Thank you.
I understand. Yeah.
Yes, thank you, Sonia. And Sonia had advised me And I had personally invited at least a dozen pediatricians to attend this talk, because I don't know whether I can say that I was relieved to see that even in the UK, pediatricians do not refer patients to pediatric surgeons well in time. And this is where what sort of Sonia has been advocating, and we are trying to influence, trying to tell our pediatric colleagues that this thing, as soon as you suspect, you rather get a pediatric surgeon to see sooner rather than later. And that doesn't seem to be happening. So anyway, I think we will just have to keep conveying to our pediatric colleagues that please refer these patients as soon as possible. Now I'm going to, yeah, Dakshish?
In UK, we have a huge respiratory physicians, a pediatric respiratory physicians body, and even I must have given at least 200, 300 talks around the place, and people have referred me earlier and earlier. However, it is an ongoing struggle, and once you come out of the practice, people go back to where they were, and they tend to listen to their bosses who tend to put the pigtail catheter. So it is difficult, but as long as they recognize the failures and refer you after the failure, that also is a bonus, because then also we can get the child better earlier by intervention.
Yes, I'm sure you have handed over the torch to some other competent colleagues, but no, thank you for that. Now I'll invite Dr. Selo Machaya. Dr. Machaya is a consultant pediatric surgeon, and he has actually mentored Kirsty Pedersen for this talk. So Selo, please give your comments.
Thanks, Rob. Thanks everyone for your contribution. We definitely are learning from hearing from everyone's experience. And what I'm gathering as well is early referral is definitely always better than delayed. But unfortunately, it seems it's not just a third world population or issue, difficult challenge where we get late referrals, because as Sonia is mentioning, by the time we get any child with any pathology, it's usually 3-4 weeks down the line. Once the child has stayed at the periphery and they've tried with the antibiotics and changed antibiotics and started TB treatment, and they're seeing TB treatment is not working, and then they refer the child saying that, okay, TB treatment is not working, we think it's a resistant TB or something along those lines. So I think from everyone's perspective, knowing early referral actually helps in the long run for the better outcome of the child is rather beneficial. And that also goes in part with how it kind of changes, I think, the management, which I'm up for correction from Sonia, in that with the earlier presentations, you could consider vets, but with where we are, unfortunately, from the anesthetic side, they only have a certain size tube. I think it's a 28 size to do single lung ventilation. And even if they do that, that's only literally, I think, for a child who's 30 kg or about 8 years old. So it's for more older pediatric group. And even if you're to consider just doing a bronchial blocker, which in our setting, unfortunately, we don't have, that means that you can attempt, but it makes doing any VETs a bit challenging when you haven't actually tried to isolate the lung. But I think going forward, the important thing is that early identification from the pediatricians and early referral to the ped surgeons and the cardiothoracic surgeons would definitely alleviate the burden we're having now. And even using fibrinolytics as it's the problem with delayed referral. I think that's where it comes, where you can't initiate it necessarily early. And I think also with not ignorance, but lack of insight into knowing that fibrinolytics can be used in lung empyema and not only just the chest drain, would go a long way. And once you've identified it's an empyema, you put a drain in and maybe even do fibrinolytic early on, because the current literature suggests that, but in reality, we have to adjust how we treat our patients according to the pathology, according to their delay in presentation, and not treat them as an empyema and class them all as how empyemas present in certain parts of the country or certain parts of the world, and treat it individually. So individualized treatment per patient, where we can't put them in the same box or in the same thing altogether. But yeah, I think that's my 5 cents, Prof. Thanks.
Thank you, Selo. Thank you.
Prof. Selo, we don't isolate our lungs. We have a bilateral ventilate both the sides at the same time. We have never isolated an empyema ever. So there is no need to isolate the lung. That's all I can say.
Oh, thank you, Dakshesh. That's important clarification for us. I will now invite Dr. Majola. Dr. Kululeko Majola is our other consultant pediatric surgeon. Also does, like the Dr. Machaya and Manikchand, does thoracoscopic work. So Dr. Majola, any comments?
Hi, thank you, Prof. I think Siloj has just sort of run through most of what I wanted to say. But what I just wanted to ask Dr. our guest, when it comes to as Dr. Van Riet mentioned, that they sometimes get deformity of the lung or the chest because of contractions. How do then they go about releasing that lung? Do you really cut out the whole pleura covering the lung, or do you cut out part of it? I just want the technicalities of how they do it.
It's for me, is it? I tend to remove as much as possible, except for the mediastinal pleura. So we tend to decorticate visceral pleura as much as we can, not the mediastinal side, because you can damage a lot of structures. So if you can decorticate the visceral pleura on the side, on the periphery, as much as you can, the more you do, the better it is, leaving the mediastinal pleura. So then you can achieve reasonable lung expansion. That is during decortication.
Yes, thank you, Dakshesh. Dr. Majola, any other comments or questions?
No, Prof. Thank you.
Now I'll invite Dr. Yashoda Manikchand, our other consultant pediatric surgeon, to make any comments, ask questions. Yashoda.
Hi, Prof. Yes, thank you. And thanks to Dr. Parekh for his wealth of knowledge. It's really, it's great to get your expertise on the subject. And thanks to Sonia, who gave, a picture of what we are experiencing in our setting, which I think is really important, especially, there's a lot of places with similar resources to us and similar difficulties. And I just want to highlight to our juniors and the pediatric surgeons who are watching is that we tend to see a lot of the secondary empyema. And if I can use a double negative, it's not uncommon to have these complications with the surgeries that we do. So I know from my limited experience as a consultant, we've seen a few esophageal perforations, central lines leaking into the thoracic cavity, and complications of thoracotomies for esophageal atresias resulting in empyemas. And my experience and my advice to the juniors would be, and I think I echo Sonia's sentiments, that early surgery is really important in these kids. And I'm talking about more neonates, but especially with the very septic neonates, I think early surgery, it can be life-saving. So what we do is thoracotomies. I think that is somewhere in our future, but especially with these kids, they tend to be quite severe or complicated. So I would opt for an early thoracotomy. And I think that's been working so far for us. So I just wanted to give our experience. Thanks, Prof.
Thank you, Yashoda. Yes, you have highlighted like secondary empyemas due to esophageal injuries and complications of central line, which I'm glad about. And if I want to put it very simply, I mean, to teach a medical student, empyema is an abscess in the thoracic cavity. So once an abscess is formed, we need to drain it. We need to drain it adequately. And obviously we need to give antibiotics. And obviously here, because lung is involved, we need to make sure that the lung is expanded properly. So I think that those are very, very important messages given by all of you consultants, Mr. Parikh, Sonia, all of us. I see Dr. Yentel Kamit, who is a consultant at Red Cross, is with us. Yentel, you trained in Johannesburg, now working in Cape Town. Any comments, anything different done in Joburg or in Cape Town?
Hi, hello, Dr. Chitnis. And thank you so much that I can be part of this talk, even though I'm not part of the institution. It's great that knowledge is shared this way. If I think about my experience at WITS, at Baragwanath Hospital, there were no cardiothoracic surgeons. So these patients were referred to us and usually to Derek, who did these. And I would say that the approach, while the referral was very delayed, so the patients were usually very ill with a lot of lung damage already. And the approach was quite aggressive in terms of decortication, like a large area of pleura always had to be removed. Mm-hmm. And then at Charlotte Maxeke Hospital, there was actually a department of cardiothoracic, so I didn't see any of those during my rotations there. And at Red Cross, I still haven't had any personal experience, but it seems to be kind of a multidisciplinary share between the Department of Cardiothoracics, pulmonology, and pediatric surgery. And there is, I think the third Monday of every month, there is a multidisciplinary clinic where these patients are discussed, but I don't really have experience of it. I just have an awareness of it.
Thank you, Yentel. Thank you for sharing your experience. I think we are coming towards the end of the meeting. So I'm going to request Dakshesh maybe to just give a final concluding remark, take home message for all the colleagues from South Africa, USA, Caribbeans, Pakistan. Please, your final words, Dakshesh, and thank you again very much for joining us. And I will certainly rope you in for any other thoracic talks in the next year or year after that. So please, your final comments, Dakshesh.
It's very good. Even I tend to revise my thing before I give you a talk, because I haven't talked about this condition for a while now, because since I'm retired, so it's great to revise it again.
Yes, yes.
And re-enter the situation. But I think is very good. One of your trainee is in Birmingham at the minute doing a consultant job, Vandermeer. From Red Cross, I think. Is she from Red Cross?
She's from sure. Red Cross, yes.
Anne-Marie. Yeah, so she's with us in Birmingham Children's Hospital. Yes, I haven't been with her at all because I had retired. I'm going to go back to work to help with the COVID-19 cases waiting list. But other than that, I'm off the thoracic work altogether. But no, it's nice. I learned a little bit about TB, which I have lost touch with. But yeah, TB is something which I definitely had worked when I was in India with. We had a Shiveri TB hospital, and my consultant used to take me over there to help with the TB cases. But that's long time ago, and as I said, I've forgotten management of TB as such. So sorry about that, but I think overall, even for me, it is educational. And as long as we have said, number of people, early diagnosis, early referral, and early management will improve the lung expansion and the overall outcome. Thank you very much.
Thank you, Dakshesh. Have a good evening. And we hope to see you maybe next year or year after that, certainly. And
yeah, whenever you wish.
Yes.
Yeah. Whenever you
very-
wish. I'm happy to join if it is something which I can contribute. Okay.
No,
Great.
thank you. We will certainly keep that in mind. And thank you, everybody, for attending and for being patient with our technical issues. Next week, Dr. Jula, our registrar, is going to talk about hypoglycemic, hyperinsulinemic hypoglycemia in newborn, and Dr. Nirav Patel from Johannesburg will be the invited guest. So you will get invitation for the meeting next week. And everywhere, thank you for joining again, and have a good day wherever you are. Bye-bye now.
All the best.
Bye-bye.